I think that we have some time to open the discussion, and I will start with a question for both of you. You said in your last slide that these type 1 interferon antibodies may have an impact on other viral diseases. And as we are in an HIV Congress, and we are talking about today about HPV infection and anal cancer, my question is, what we know about these antibodies and the progression to AIDS in untreated HIV-infected patients, or reservoir size in treated HIV-infected patients, or anal cancer progression in general population and in HIV-infected patients? Is there any information about that?
So, to my knowledge, I don't know, but I think we should really look at them. But I don't know.
I don't know either, but I think it is a great question because interferon alpha is very important for prevention of HPV-related cancers, and I learned something very important today. So we could certainly look at that in patients who are enriched because they have either high-grade disease or cancer. And the association with age, again, is something else that seems to be consistently coming up.
Thank you very much for your two great presentations. I would like to ask to the Dr. Palski, I think a hot topic on anal cancer screening. What is the ideal age, the threshold age for starting, and if we have some risk factor or prognostic factor to make this screening earlier or later? Because this is a
yeah, great question.
Critical question.
So actually, I feel reasonably confident in answering this one. We looked actually, when we made the recommendations to the CDC, we'll see if they accept everything. But what we suggested to them was that for MSM and transgender people, we start at age 35. And we wanted to make sure that younger people are left alone, because even though, for example, I showed that a third at the age of 21 had a high-grade lesion, it doesn't mean they're going to get cancer when they're in their 20s. And I think they should just be left alone because the risk-benefit ratio does not favor messing their lives up at this stage. But if you look at the cancer rates, they do start to tick up in the mid to late 30s amongst men and transgender people. And then for everybody else with HIV, we're suggesting 45, because women tend to get cancer older than the men. So I think that's a good place to start. But even with that, the issue is, particularly if we're going to recommend cytology or HPV testing, we're still going to end up with too many people that we need to refer for HRA. We're not going to cut down very much on the number of referrals by eliminating people based on cytology or HPV. So I do think there's some additional factors that you can consider. One is age. So if you have a population of 100 people, I'd probably work my way down in opposite order of age and start with the oldest, or at least the people who you knew were HIV positive the longest. Another one I would use as an additional stratifying factor would be somebody who smokes. And not only does that increase the risk, but it's also an opportunity to engage with them and try and encourage them to get into cessation programs. So those are two very important ones. And then, of course, it goes without saying that when we're talking about screening, we're talking about people who have no symptoms. If somebody has symptoms, then by definition, they should be sent right away for HRA. People with bleeding and unexplained new growth, pain that's not otherwise explained, all those things should prompt an immediate HRA.
Thank you. Tenemos preguntas.
No sé, hay preguntas. Sí.
Tenemos preguntas.
Sí, buenos días. So thank you, Dr. Puel, for the great presentation. In terms of clinical implications, these patients without antibodies, they have severe COVID pneumonia because they have more prolonged viral replication and they need probably longer treatment with antivirals, or is that they have more inflammatory response and they need treatment with more anti-inflammatory drugs?
So thank you. So apparently at the beginning, because of these autoantibodies, the interferon type 1 interferon response cannot be mounted, and the virus is replicating, and then it's spreading, and then it's activating the other cells, and then they resist cytokine storm. So we think that yes, at the beginning they prevent type 1 interferon to do their job and eradicating the virus, and so and associated with the cytokine storm in a second step. But I probably haven't responded to your question.
Well, the other question is very quick. Can we have a rapid test?
The rapid test?
Yeah, for autoantibodies.
So it's pretty easy. So either you have ELISA. We're not doing ELISA, we're doing a gyros, but I think that progressively there are a number of labs who are developing those autoantibodies detection. But so up to now, we are the only lab assessing their neutralizing activity. So we're doing it, so we're screening thousands and thousands and thousands of samples to assess not only the presence, but the neutralizing activity. So if needed, just contact us. Yes.
Yes, thank you, Dr. Puyal. I have two questions. One is regarding APS syndrome, that is related with this deletion in the ER gene. Have you looked at the potential polymorph ER gene in these patients that could give a non-endocrinopathy phenotype, but the anti-interferon antibodies that have been described in this condition?
So for many of these patients, we are also performing a whole exome sequencing, and for some of them, whole genome sequencing. So we are trying to understand which are if there is a genetic origin for the production of these autoantibodies. So we also look at, in particular, R. So we're looking at if there is any variance in R. So for some patients, we have identified a heterozygous variant of R, and we are investigating them. But it's only a minority of the patients with autoantibodies against type 1 interferon.
Okay, and the second question is age. Why in elderly patients these are increased? Do you think it's a lack of tolerance due to immunoregulatory mechanisms, or could be, for example, the reactivation of herpes viruses to influence the induction of such anti-interferon antibodies?
So all the questions up to now are fantastic questions. Sorry to. So that's a very important question. So every inborn error up to now, which has been associated with the production of these autoantibodies, is associated with a thymic problem. So, and we know that there is a thymic involution with age. So is this related to a thymic involution? That could be it. The other thing is because we're aging, our cells are producing more and more RNA. So do we stimulate the interferon alpha, the type 1 interferon production, and progressively we lose our tolerance against type 1 interferon, which are produced, and at some point we do produce those autoantibodies with aging. It's another possibility. There are many possible causes that we don't know yet. But thymus dysfunction might be explain some of the cases, yes.
Thank you.
Thank you.
Work.
Thank you.
Thank you very much.
Dr. Palevsky, congratulations for your excellent talk and also for carrying out the ANCHOR trial. I have a simple question is, in the ANCHOR trial, almost 50% of people that were screened turned out with HSIL. My question is can we assume that that is the real prevalence of HSIL among this population, or is there any kind of bias because they were recruited in, let's say, hotspots in special clinics for anal cancer screening?
Yeah, that's a good question. So for the men, the numbers were not that different from previously published studies. So I think the numbers are real for the men. Where we saw the biggest surprise was in the women, because the study that we'd actually participated in before that showed the highest prevalence of HSIL in women was 27% in an earlier AIDS malignancy consortium study. So the question is, which of these two prevalences is more representative? It's probably somewhere in between, would be my best guess. I think we did have maybe some bias towards higher risk in the anchor population. There's a lot of reasons for that. We took some very special measures to recruit and retain people to the study, and it may be that we attracted people at especially high risk because of that. But that wasn't the case for the earlier AIDS malignancy consortium study showing 27%. So one way or the other, it's really high is the important thing, and it's especially high for transgender people. One other thing I'll just point out before I finish my remark is that this study took a long time to get done, because one of the things we wanted to do is make sure that everybody who was seeing patients met the very highest standards of competence in high-resolution anoscopy. Historically, some of the problems in the field have reflected the fact that it takes quite a long time to get really good at HRA, and a lot of people were publishing data showing prevalence of disease and disease associations maybe before they were fully competent. We saw that ourselves. When we look at our oldest papers, we saw a relatively low prevalence of disease, and then it kept on going up over time. Was that a true incident disease, or was it that we were just getting better? So we thought that it would be important for a one-in-a-lifetime study like ANCHOR to make sure that everybody was starting off at the highest level possible, and that may also explain the higher rates of high-grade disease that we saw.
Okay, thank you.
Dr. Palevsky, thank you for your talk. I would like to ask you, how many persons living with HIV over 35 years would we need to screen for HSIL and afterwards treat to prevent one anal cancer?
Yeah, I did the back of the envelope calculation for that, and frankly, I don't remember that number off the top of my head. But what I can say is that number is very favorable compared to the number of women who you have to screen for cervical cancer to prevent a case of cervical cancer. So we're in the process of doing the cost-benefit analyses, including the quality-adjusted life year, et cetera, and all I can say at this point is that we're fairly confident, at least using based US assumptions, that it will meet the guidelines, the usual guidelines for cost effectiveness.
Thank you.
Bueno, ya hemos cumplido el tiempo, son exactamente las 9:45, lo siento por la última pregunta, pero bueno, tendréis la oportunidad de hacérsela al doctor Palevsky personalmente. Muchas gracias. Thank you very much for these super presentations. Creo que ha sido una sesión muy interesante. Y bueno, pues ahora podemos tomarnos un descanso hasta las presentaciones orales. Muchas gracias y hasta luego.